Great. Our next speaker is Dr. Aaron McKeithen. Dr. McKeithen is the director of the Beacon Communities Program at the Office of the National Coordinator for Health Information Technology. Dr. McKeithen's article is provocatively titled, Uniting the Tribes of Health System Improvement. Dr.
Thank
McKeithen.
you. Thanks, and I joined the panel in congratulating the journal for putting together such a great issue, and a provocative one at that, a thoughtful one, and for the fellow colleagues here on the panel. Sachin's right that our commentary really focused, my colleague Craig Brammer, also at the Office of the National Coordinator, and I have been thinking about what's going on at a macro level in health system reform. And all of us in this room and many others around the country for the last several decades have been thinking about the problems of health system performance and the gaps in quality and efficiency that we all observe and experience. But doing so largely in distinct groups with distinct sort of worldviews about what might constitute improvement. So we have the quality improvement folks who rightly observe that quality improvement techniques and management philosophies from other industries have not been, for some reason, applied consistently to healthcare. And so you see examples of this group of researchers and policy leaders and experts trying to deploy lean production methods and performance measurement and feedback and continuous improvement techniques to do things like reduce infection rates in hospitals and so on. And those have been extremely impressive in this quality improvement group. Second, you have the payment reform group, which I think I've spent probably most of my time in. And those of us in that group read MedPAC reports, and we get excited about market basket updates and issues like that. But we've been rightly pointing out, I think, that when we are paying as a system for volume and intensity of services, it tends to be what we get. But of course, the limitations of those of us thinking about payment reforms is that just changing payments at the margin doesn't actually change practices. It turns out you actually have to incorporate some continuous improvement and quality improvement activities and approaches to generate those kinds of results. The third kind of group that we describe is the patient engagement or activation group or tribe, and these are folks that have rightly pointed out that we really have to do a better job of engaging, equipping, and encouraging patients and their caregivers in this system in a whole range of ways, and developing a whole range of tools to do it, to make healthcare decisions and lifestyle choices based on best care and best available evidence. And again, impressive studies, impressive results from demonstrations or pilots of these kinds of tools to engage patients. But the limitation is that even the most engaged and equipped patient, when left with a complex and a complex health system, you're still left to migrate this complicated system on your own. So there's an inherent limitation in those kinds of approaches if that is our only approach to thinking about health system improvement. Finally, we have the health IT tribe, and these are folks, many of them are at the Office of the National Coordinator.
We have the chief of the tribe right here.
That's right. And we've rightly, I think, made the clear observation that it's really hard to improve anything if we're stuck in a paper-based system and can't really measure improvement and can't figure out which patients to call for follow-up and so on. So our modest contribution to this otherwise exceptionally well-done journal is to simply point out that we are in a time of great change where we're starting to see those tribes coming together, with IT playing a really critical role in helping us to think about how to unite quality improvement activities with the kinds of payment reforms that will make those improvements sustainable. A good example from our work in the Beacon communities is we have 17 communities around the country that have we organized a national competition to select 17 out of what was about 130 applications of communities to set specific aims for their community around cost and quality and health. not to test a particular technology, not to engage a patient in a particular way necessarily, not to implement a marginal payment modification at the margin, but rather to start by defining what we would constitute as improvement in our community. In the Beacon community in North Carolina, for example, we sure would like to see kids with asthma not show up at the emergency department because we found a way to coordinate their care using multiple interventions that span all those tribes I described, ways to engage those patients and their families around resources that can help them avoid complications, IT systems in hospitals and the medical system and physician practices, clinical decision support tools, a whole range of things. And so again, our modest contribution is to suggest that as the Beacon communities have done, our challenge is to think about first defining some really concrete, focused improvement aims, and then design the interventions and the processes that will help us to achieve that. And the great benefit of the IT revolution is that all those things really, or many of them, require an underlying information architecture to help us understand how to deploy disparate interventions all together, rowing toward a very particular set of outcomes that the community is striving to achieve. This has important implications for policy because and for the practice of private insurers and employers, because it suggests that instead of implementing a one-off pilot for, say, a marginal or incremental change in payment structure or a benefit design in isolation of other changes, we ought to be thinking about supporting the notion that it's going to take multiple interventions of varying types to really address the significant gaps that we have in our system. So it's not just that patient engagement tool or program, but it's that in combination with benefit design changes that help the patients that have issues related to affordability to receive the service that is necessary for prevention, tools in the physician practices to help them monitor those same patients, and so on. This also has important implications for the research community, because it's the very reason that we tend to set up demonstrations and pilots of single interventions is because we want a high quality of evidence for any particular change in the healthcare delivery system. So it would require significant thinking about how do we measure the effects, overall effects of a combination or a portfolio of changes in healthcare delivery, as opposed to one-off discrete interventions where the quality of evidence can be high, precisely because we can hold all other things constant. So it's provocative in that sense. It presents lots of challenges, but I think if our goal is to get really high quality evidence for any particular intervention, this is going to be a really hard approach. But if our real goal is to make breakthrough improvements in quality and efficiency at a community level with measurable aims and outcomes involving lots of people, then I think this offers, the Beacon kind of model offers one for other communities to aspire to as well, putting all these sort of disparate, previously perhaps disparate interventions and people working in tandem together. And the last point is to personify that. Yesterday in North Carolina, where I was visiting with one of our Beacon communities, the most delightful observation that was made at a meeting was that for the first time, the chief information or technology officer and his staff were actually sitting down with the chief medical officer and the kind of clinical delivery leaders that are really in charge of ensuring that patients are getting the kind of follow-up care they need. And they're working together in this one example to unite those tribes and think about how do we design technology with our goal in mind. Thank you.
We heard from Ms. Namani about the role of patients and consumers, and the fact that patients and consumers are ultimately can be beneficiaries of health information technology. What's the role of the patient and family tribe in sort of uniting the tribes?
Sure. Well, it's a good question, and there are 17 Beacon communities, and there are probably 17 different examples of how this is playing out. But I think, if you just think about some of these interventions I've described, to be more concrete about North Carolina, they're implementing reforms on both the provider and the demand and supply sides of the medical marketplace. Care transitions programs that involve following up with patients that are being discharged from the hospital and ensuring they understand their medications and have a connection to their primary care physician. In the ambulatory side, care managers that will reach out to patients when it's clear they need a follow-up service. Clinical decision support tools really focused on the provider side, and so there's a range of interventions that have both a provider and a patient dimension, and some of the interventions that have been most effective are around public engagement, helping the community understand that if we were trying to tackle a diabetes project as a part of Beacon, the public should have a better understanding what diabetes is. How do you know what it is? These kinds of these public awareness campaigns can be really important overlay on top of the medical set of medical interventions. So I think both are critically important, the medical technologies and interventions as well as broader improvement aims that involve the public. But all that's easier when we set specific goals for what we're trying to accomplish. If we were to say, in your community, imagine the mayor saying, we want to see a 10% reduction in avoidable hospital readmissions for patients that are dealing with a particular type of disease. That kind of goal setting could be really powerful in engaging the public and rallying around a whole lot of other social capital in the community to head in that same direction.
We do have one additional panelist, but I'd like a few questions from the audience if there are any.
Greg Paulson, Executive Vice President of NCQA. I'm intrigued with your analogy of bringing the tribes together, and I see two major developments that are doing that. One is the Beacon communities and sort of the community aligning forces before that. The other is the emerging concept, which is still somewhat undefined, and that's the accountable care organization, especially where it's integrated with the financing of care so that it brings that piece in. How do you think these two things may interact, and especially since we're talking about IT, how is the IT interfaces between sort of a community-based information system and a accountable care organization defined information system? How do you see those?
Yeah. Well, first I would agree with your observation that accountable care organizations have the potential to be real unifiers, because if they're viewed as payments at the margin, if you're just viewing them as an opportunity for achieving shared savings bonuses, then I think everyone in the room would agree, I'm not sure that's going to work. But if you think of it as a payment change on top of a whole range of improvement activities, performance measurement and feedback, all the interventions I've just listed, and IT as a platform, they can be really powerful agents for improvement. Several of our Beacon communities are interested in engaging with CMS and private payers on this. Some are ahead of others. But I think the work at the Office of National Coordinator on health information exchange, we have a separate whole program on helping states fill gaps in information exchange, which is a critical part of meaningful use, is going to be a critical part of what an ACO is going to have to be able to accomplish. So I think a couple examples include the ability to receive data to do performance and population-based analytics to identify high-risk patients and to report on those results that give rise to any kind of shared savings payments.
Just to emphasize, I think one of the key things that people have forgotten is one of the important pieces of data, or one of the important sets of data that an accountable care organization is going to need is people who go outside that accountable care organization. And the only way you're going to capture that is by having the data come in from all, including those who have claims and so on. Yeah. So it's an important piece.